Okay, I think we can start. Welcome everyone to this issue of the VPHi Keynote Webinar Series. My name is Christian Spieker. I'm a PhD student at the University of Amsterdam and also a member of the VPHi Student Committee. And I'm really excited that today I can announce that we have Professor Simo Saarakkala with us. Simo is a professor of biomedical engineering at the Medical Imaging Research Unit of the University of Oulu in Finland. There he is also a scientific director of the Infotech Oulu Focus Institute. On top of this, Simo has been a visiting scientist at Hong Kong Polytechnic University and University of Auckland. Simo's research is widely published and internationally recognized, especially in the fields of musculoskeletal imaging and biomechanics, where he has special emphasis on articular, cartilage, subchondral bone, meniscus, and osteoarthritis. And this is also what we will hear about today in the talk, Imaging of Joint Tissues, Implications for Better Understanding, Diagnostics, and Prediction of Osteoarthritis. And before I hand it over to Simo, one quick disclaimer. This webinar is being recorded, and it will later on be published both on our VPHi YouTube channel and website. So please be aware of that. And together with the recording, we will also publish the slides. And if you have any questions, please feel free to write them in the question box. After the talk, we will have a question and answer session where I will read the questions to Simo. So with that said, I think we're ready. And Simo, the floor is yours. Let's take it away.
Thank you. Thank you very much, Christian, for the nice introduction. And now let me try to get the screen sharing working. So can you see my screen? Maybe Christian, you can comment about that.
Yes, I can see the screen.
All right. Excellent. So good afternoon, everyone, and maybe even good evening or good morning, depending which part of the world you are listening to this webinar at the moment. And I'm really happy to present this keynote webinar today, and we are going to talk about the imaging of joint tissues, and mainly as a perspective of osteoarthritis. So this is the content of the talk today. So we first look at a little bit on osteoarthritis in general, and then we go more specifically for the imaging methods that we have been investigated for over 10 years here in University of Oulu. We mainly talk about the ex vivo imaging, high resolution imaging methods, but at the end of the presentation, I'm also presenting some of our research regarding in vivo imaging and focusing on knee radiography. So let's start with osteoarthritis as a disease. So it is actually the most common joint disease in the world. In Finland, we have over 7% of adults over 30 years suffer from knee osteoarthritis, and this increases progressively when we go to the higher, older age groups, and it causes significant individual and society level burden. At tissue level, degeneration of articular cartilage tissue, osteophytes, sclerosis of subchondral bone, joint effusion, and synovitis are all characteristic tissue level changes in osteoarthritis. We don't really understand the etiology of osteoarthritis really well at the moment, but recent evidence suggests that it is not a single disease, but instead it is a group of diseases manifested in different phenotypes. There are really different categorization of phenotypes in the literature. There are a few phenotypes presented on this slide. So metabolic osteoarthritis, which includes the obesity, traumatic osteoarthritis, also including joint malalignment, inflammation-driven disease, which is can be more related to the rheumatoid arthritis, and also subchondral bone turnover-driven osteoarthritis. All of these can manifest themselves a little bit different changes in the tissues, and especially in different order, even though in end stage we very often end up in a situation like this. So this is the very famous picture from 1995, which shows quite nicely what is happening inside the joint tissues in osteoarthritis. And as you can see from this figure, articular cartilage tissue seen here, this is the most osteoarthritis is most commonly characterized by the degeneration and wear of this articular cartilage tissue. But a lot of other things are also happening in the joint, like thickening and sclerosis of the subchondral bone, and also this is now the hip joint. So in the hip joint we don't have meniscus, but in the knee joint we do, and there are actually a lot of changes also happening in the meniscus tissue. So it's not only about the disease of articular cartilage wear, like the traditional view has said. So we know that it's a complex multifactorial disease, including the whole joint as a unit. And this is typical, and with the current, we don't talk about so much of the diagnostics of osteoarthritis here today, but typically it is diagnosed quite late stage, so we are quite often going somewhere here, and it would be much better if we could already be able to detect the disease when it's in really early phases. This is a question that I get quite often when giving speeches about osteoarthritis diagnostics. So why does early diagnosis and detailed imaging of joint tissues matter, especially because there is no effective cure for osteoarthritis at the moment. So we don't have any medication which would cure the disease. So at the moment we can only slow down its progression. So many often I get asked by especially medical doctors, why bother? Well, the answer is that, as I said already, if we could detect the disease at an early stage, we could slow down the progression or even halt it completely. But maybe even more importantly is that if the humans will ever will come up with the new treatments, we need very sensitive diagnostic techniques so that we can select the proper patients to the treatment trials. And this is not possible with the current clinical methods. And then, of course, as a fundamental biomedical researchers, we need to really good methods to understand the early structural and compositional changes in joint tissues in very early phases. And why is that important to understand those changes? Is that when we talk about the joint tissues, they all have a biomechanical function in the joints. They actually control the biomechanical behavior eventually. So we need to really understand the early phases. So now let's focus on some of the ex vivo imaging methods we have been studied as I said in our lab for the past 10 years. So all the current in vivo clinical modalities, they lack the spatial resolution to characterize very early changes, especially at the micrometer or even if we go beyond micro level. And we have been studied several of these imaging methods and validated them for imaging of articular cartilage, subchondral bone, and meniscus. FTI and Raman Microscopy is one technique that you can use to get the composition and content distribution in 2 dimensions. Polarized light microscopy is a method what we also studied when looking at the structure and fibrillar organization in 2D, and then especially for the last 6-7 years, we have done a lot of work with micro CT, which is a 3D method. And now today we are going to see a little bit more what you can get out from these methods. So let's start with the FTIR microscopy. So in FTIR microscopy, you basically you combine the infrared spectrometer with the traditional microscope, and you can get the typical microscope resolution around 10 micrometers. You can have a tissue sample sections which you can visually observe under the microscope, the same way than typically in microscope slide. But you don't need any stainings in FTIR spectroscopy, because basically you measure the infrared absorption through the sample section. And it means that when you measure the infrared absorption, it means that in each of these pixels that you image, you get the absorption spectrum. And from this absorption spectrum, you can analyze different content or different molecular composition of the sample. So one common way for, when we image the articular cartilage is to analyze the collagen and proteoglycan content. So two primary components making up of the articular cartilage tissue. And when you take the certain areas of the infrared spectrum, you will be able to then analyze the content of this certain component. For example, here we have a human cartilage samples from normal, early osteoarthritis, advanced osteoarthritis, and we see the decrease of the collagen content and also the proteoglycan content here. And again, these doesn't require any staining, so these are unstained sample sections, just the infrared absorption spectrum is measured, and then this is kind of a pseudo color, so we just use certain color to describe the absorbance of the infrared light in this certain wavelength. We have also validated that besides just an collagen and proteoglycan content, you can actually probe the collagen cross-linking and maybe even separate the different types of collagen cross-links, like we did in our study a couple of years ago. Another important imaging technique in vibrational spectroscopy side is Raman microscopy. And in Raman microscopy, instead of measuring the infrared absorption, we measure the laser light scattering. And similarly, as in infrared spectroscopy, we measure the spectrum, so we measure the scattering of light in different wavelengths, and we get the scattering spectrum. In Raman microscopy, you can go a little bit better spatial resolution than with FTIR microscopy. So if we go back, so FTIR microscopy, we are typically in the range maybe a few micrometers up to 10 micrometers, but in Raman microscopy, you can image the tissue even 1 micron or under. Raman microscopy has some unique advantages compared to, for example, the FTIR microscopy. So as I said already, it has a high spatial resolution, and also water and carbon dioxide are quite weak light scatterers, so we can also measure hydrated samples directly, which means that we don't need to dehydrate necessarily the sample, so we can measure the tissue sample in their physiological environment, and we don't really need too much of a sample preparation. So basically we just need a flat surface where we can measure the scattering. And Raman microscopy in this situation gives information about both mineral and organic components of the tissue simultaneously. And because of that, it is especially well suited to characterize mineralized tissues. And now when we think about mineralized tissues within the joint, we talk about calcified cartilage and subchondral bone. And this is what we have been doing in our lab. So last year we published a study in Acta Biomaterialia where we looked at the Raman microscopy analysis of human osteochondral junction. So basically we looked at the interface between the articular cartilage and subchondral bone. And we look at the mineralization stages there at the interface. We also use the sophisticated analysis algorithms to automatically find the different tissue types, like the non-calcified cartilage, calcified cartilage, then the subchondral bone plate, even the bone marrow and osteocytes. And we can separate the spectrum to mineral, vibrational range, and organic range. So we can basically analyze the collagen and proteoglycans from the cartilage and also from the subchondral bone in the organic range. And then as in the mineral range, we can analyze the mineralization and, for example, the ratio of the how much mineral you have within the matrix. And all of this you can do with very high resolution and in a focused way. Another technique, important technique that we use in our lab is polarized light microscopy. In PLM, you pass a polarized light through an unstained histological sample section, and when transmitting through the sample, light polarization changes depending on the organization and orientation of structural components of a sample. When we talk about structural components in biological tissues, also in joint tissues, collagen network is the main framework which basically changes the light polarization state. And this is a quantitative technique. So these kind of images you can get from the polarized light microscopy. So here we have an images of two visually intact articular cartilage samples. Here is the surface, and here is the deep cartilage. Surface here and deep cartilage here, and these both samples are visually intact. They are extracted from the patients who went to the total knee replacement surgery, but they came from the joint surface which were visually intact. So surgeon said that this is a perfectly good looking cartilage tissue. So here on the left sample, we see that the collagen network. So basically, these colors describe the orientation of the collagen network, and it is now color coded according to this circle. So here we see some pink and red colors at the surface. Pink and red is oriented according to this circle. So it is oriented like this. And here we see some green color at the deeper tissues. Green orientation can be looked from this circle, so it goes like this. So basically, this sample here shows the unique Benninghoff organization of the collagen network, which is typical for the normal healthy articular cartilage. But as you can see, situation is completely different here on the right side, right sample. So this is also visually looking normal. So orthopedic surgeon said that this is looking normal. But we can already see that the collagen network in this sample is highly unorganized compared to this normal organization. And polarized light microscopy is really nice way to show it from the tissue sample sections. And again, remember, there is no staining. This color comes from the light polarization state changes, and it is color coded according to this orientation. So you can use unstained sample sections. So this is then how the severely degenerated sample look like. So this is then the as you can see, part of the cartilage tissue has already completely worn out. So this is obviously a sample then also the surgeon can see right away that this is not looking good and is missing part of the cartilage already. And we can see even some formation of the new fibrocartilage. So basically tissues attempt to repair the damage. So you can visualize it very nicely here with the PLM. So these two techniques are the ones that we have been used for 2D analysis. So again, as I said, we have used the sample sections. So basically we look only one section at a time. So it's a 2D technique. But micro-CT is a technique that you can use to obtain high-resolution 3D images from a tissue sample, and you can do it with fairly good resolution also. With the current devices out there at the market, you can go below one micrometer. Subchondral bone, it can be clearly visualized in native micro-CT, but when we talk about the joint soft tissue, such as cartilage and meniscus, they are not easily visible in normal absorption-based micro-CT. So typically you need some contrast boosting method. And there are, in the literature, there are published contrast methods for imaging of proteoglycans and collagens of articular cartilage and meniscus. This is what we are going to look like now. Look next. So we published in 2015, we published a contrast method using the phosphotungstic acid as a contrast agent. So phosphotungstic acid is basically chemically binding to collagen network of the articular cartilage. So here on the left, you see the slice by slice video of the, so this is the bone, this is the cartilage, and here you can see the staining of the cartilage with this PTA. You see higher stainings here at the deeper layers than at the surface, which is normal because the collagen content is higher here at the deeper layers of the cartilage than at the surface. So this is the normal collagen distribution. So basically this PTA goes there according to the collagen distribution. And of course, with micro-CT and as a 3D method, you can always reconstruct, do also nice 3D reconstructions of the tissue samples. We also developed the histopathological grading for micro-CT imaging of osteoarthritis, cartilage and bone, and 3D histopathological grading for osteoarthritis. This was published a few years ago, which basically researchers can use if they want to do more thorough grading than what you can do in normal conventional histology, because there you look only the sample sections, one section at a time, and it's fairly time consuming and hard work to sample those few micrometer sections to every areas of the joint. But if you use this kind of micro-CT approach, you can actually look at the whole tissue volume and do the grading there. We have also tried to automatize the grading. So this was the semi-quantitative grading in a way that you have a grader, and you basically go through the image stacks of micro-CT, and you give the certain grade based on this grading scale. But we have also tried to automatize that using the deep learning, and we published last year that you can, especially at the surface layer of the cartilage, you can automatize this grading fairly well. So maybe in the future, actually, we would be able to, a computer would be able to give you the severity of osteoarthritis from the cartilage bone samples when imaged with micro-CT. We have also studied another contrast boosting method. So that was this phosphotungstic acid, what I showed you. But it's also possible to get the contrast to articular cartilage, and actually also also any other soft tissue using the dehydration of the sample. So you can use the hexamethyl desilazane to dehydrate the sample. So basically, you take all the liquid and all the liquid out of the sample, and what you have left, you have only the solid matrix, and then when you image that with micro-CT, contrast comes between air and the solid matrix, and that actually is able to give you a fairly good contrast. Of course, you need to fix the tissue because otherwise it might collapse. So, but this is a kind of a nice way also to get the contrast to micro-CT for soft tissues without adding any other chemicals there. So basically, it's kind of a natural contrast just without water, a liquid phase. So here is kind of a micro-CT image of the cartilage surfaces. Here would be bone. So this is our cartilage sample, little bit degenerated sample. And if we compare that with the histology and polarized light microscopy, we see that you can actually see the structure, the collagen bundle structure fairly well also already from the micro-CT. And of course, this is 3D again as a reminder. So you can always analyze it section by section, or you can make the 3D reconstructions and look at the sample in 3D. Here we have a bone, here we have a cartilage. This is a healthy sample, and this is a mildly osteoarthritic sample. Not yet end stage, because you still have quite much cartilage left there, but you can see really well that this is not certainly a normal healthy sample. And of course, besides these nice visualizations, it is possible to also do image analysis, do quantitative image analysis, and obtain some quantitative parameters for describing the changes, what is happening there as a function of disease severity. In this study, we use this dehydration contrast method to look at what happens to cartilage cells, chondrocytes, or more specifically chondrons. So basically the spots there, as you can see in the cartilage tissues, which includes one or more chondrons within. So we showed that the morphology of these chondrocytes changes as a function of severity of osteoarthritis. So chondrocytes are not staying there in their same position, even there at the deeper tissues, which still hasn't worn away during the disease progression. So this is one thing that you can do with the from the micro-CT dehydration scans to look at the chondrons. Then let's move to another very important tissue, joint tissue, which is meniscus. So we have also studied a lot in collaboration with the University of Lund, or Lund University, with Professor Martin Englund's group. We have studied meniscus and tried to understand what is happening in meniscus during knee osteoarthritis disease process. And we found out that this dehydration HMDS contrast method seemed to work really nicely and give really nice images also of the meniscus. We saw that it is very much comparable to conventional histology. So here we validated the imaging technique against histology. Again, as a reminder, we can look at the structure in 3D. So on the left, we have a healthy meniscus sample, and on the right we have the osteoarthritis meniscus sample. And as you can see, you can really nicely visualize what is happening in the tissue matrix in osteoarthritis. And actually, you can see even like the most thick collagen fibril bundles with in these micro CT scans. So in brief, micro-CT is also highly suitable for studying the meniscus tissue microstructure. And also here, this is a work published just a few months ago. Months ago, we also wanted to quantify the principal direction of these collagen fibers as a function of different osteoarthritis severity stage. So besides just getting nice pictures, you can actually get some quantitative numbers to describe the organization of the collagen fibril network within certain volume. In our case, we limited our analysis in this study to this kind of a cubic volume in middle of the tissue or meniscus sample. And besides that, we have also shown that the micro-CT is really good method to look at the calcifications within the meniscus. So it is known that in osteoarthritis, in quite often we see calcifications in meniscus. You cannot see them very clearly in histology unless you have really much calcifications there. But in these early early disease phases, you don't see them, you don't see the calcification that well in normal histology. But in micro-CT, when you do a specific scans which are designed to look at the calcified stages, you can actually see them really nicely. You can even quantify them. We haven't done that yet, but we will. But what we did in this is a truly new data came out from a couple of weeks ago. So we graded the calcifications from these meniscal samples, and we look at it. We look at how the calcifications behaved as a functions overall osteoarthritis, and this was really interesting finding, because it seems, based on this preliminary data, that there are two types of meniscal degeneration processes. So one without calcifications and another one with calcifications. And actually our collaborators in Lund, they said that they see also this supports also their clinical findings, but this is really haven't been shown earlier, because calcifications are really difficult to analyze comprehensively in histology. But in micro-CT, it seems that you can do it, and when we analyze these further, we will actually learn some new aspects of what is happening in meniscus in osteoarthritis, and maybe even there has been even a discussion, especially by our collaborator Professor Martin Englund from Lund, that could there be a meniscal driven phenotype in osteoarthritis, basically where the disease would originate from meniscus. We don't know that yet, but I hope that we will eventually find it out. Okay, so far we talked about the non-calcified joint soft tissues, but so then when we move to the calcified tissues, like as a tide mark, interface between the non-calcified cartilage and calcified cartilage, and then when we go to calcified cartilage and subchondral bone, so and use the micro-CT, we don't need any contrast enhancement. So bone absorbs X-rays so much that you can see the bone and the calcified cartilage without any contrast enhancement. Again, here when we have imaged quite much of the human osteochondral samples within the last 7-8 years. We can quantitatively analyze the tide mark, so this interface between the non-calcified and calcified cartilage. We can analyze the morphology of that, and also we can quantitatively analyze the perforations of the tide mark. So these perforations mean these kind of channels which might contain vessels, or they might be also some other channels, maybe even some nerve channels, especially at the deeper of the bone plate. So you can see these channels with micro-CT, and you can analyze how much channels you have in different disease stages. So this is what you can do with the micro-CT, and especially it's good to remember desktop micro-CT. So basically the device that we have in Oulu and many others have in lab. But then if you go one step forward, you go to the synchrotron micro-CT, where you have really a coherent X-ray radiation, and you have advanced imaging techniques. You can go even deeper, and you can analyze the osteocytes, so bone cells, and morphology of them quantitatively. So basically, so you can, for example, separate the individual chondrocyte and cluster of chondrocytes and look at how the clustering changes in different disease stages. Okay, so we have been talking about the ex vivo imaging. So as you see, so far we have only imaged the tissue sample. So one may ask the question that, okay, does it have any clinical relevance besides just understanding what is happening in the tissue in micro level, which is of course per se really important, but also we have been studying that would it be possible to bridge the gap between this laboratory and clinical imaging of osteoarthritis. So So in hospitals nowadays, these cone beam computed tomographies are more and more common, and with these cone beam CT devices, you can go to resolutions 200 microns, some devices even 100 micron. Okay, with micro CT, you can go to resolution few micrometers, and this is actually the same sample here, imaged with this clinical device in our hospital, and then in our laboratory device. So here is the subchondral bone, and here is the trabecular bone, and this is how it looks like with clinical scanner. As you can see, obviously you cannot, resolution is not very good. But the question what we can ask, that nowadays with our advanced AI-based deep learning, other machine learning methods, could you actually predict from this blurry data, could you predict what is happening there in truly high resolution level? We started to investigate that more carefully, and we imaged these tissue samples, human tissue samples extracted from donors and patients who went to total knee replacement surgery, these small sample blocks. We imaged them with micro CT, and then we imaged them with cone beam clinical CT. Again, here you can see the differences in image quality. What we did then, we analyzed the texture. We did the three-dimensional texture analysis of these pixels from this clinical CT scan, and correlated those with trabecular bone parameters from micro CT, like bone volume fraction, trabecular thickness, trabecular separation, trabecular number, for example. And as you can see from the graphs on the right-hand side, so it seems that this fairly simple texture parameters, when analyzed in 3D, they seem to associate with the true micro-level bone structure. So this was our first attempt, and at the moment we are developing this idea forward. So this was quite a simple study in that sense, that we just analyzed certain volume here and analyzed these texture parameters and associated them with reference parameters from micro CT. But here in this study, which is currently ongoing, we are using the deep learning to artificially increase the resolution of the clinical CT scanner. So this is called the super resolution technique. If you look at the deep learning literature and deep learning super resolution, you find a lot of papers describing this. So basically it means that you need to train the deep learning model with data from two different resolutions, and then you kind of train the model to predict the high resolution image from the low resolution image. So here is an example on the side, the deep learning model done with the laboratory micro CT scan. So in model training phase, so this was the input scan. So basically the 200 micrometer resolution, and then this was the target that we wanted to train, 50 micrometers, and this is then this output. This is eventually the prediction of the model. So basically from this data, this is predicted by the deep learning model, and this is the target. So you see that it's performing fairly well, especially because we didn't have too much of these cartilage bone samples to work with. And this is even more interesting, that with this model, which was trained with laboratory micro CT, from laboratory micro CT data with these human osteochondral samples, here it was applied to completely clinical normal patient scan from our hospital about the wrist CT scan. And here is and resolution of this clinical scanner is 200 micrometers. So here, this is how the image look like. And when this model trained in the laboratory with these tissue samples were applied to this data, this is how it looks like. So it seems that actually it fairly nicely enhances the resolution of bone. Of course, at the moment we don't have reference for this, because this is the clinical data. We were not, you can probably guess why, we were not able to take a tissue sample of this patient and image it with the micro-CT. So we actually don't know what is the gold standard here, but what we do know, we can, what we can see, that at least visually it looks like that it would certainly work also for clinical bone scans. Again, which is very interesting because it was trained with only with the tissue samples in laboratory. But this is unpublished data and very, again, like preliminary results from last week. Oh, okay, at the end part of the presentation, so I'm gonna briefly show some of the research we have done for directly patient imaging, and here we focus on conventional knee radiography, so X-ray imaging of the knee joint, and what you can do with texture analysis and deep learning. So in osteoarthritis imaging, if we and diagnostics, if we think about the imaging, that the X-ray is actually the primary imaging modality. So there are recommendations that in the routine clinical management of patients with osteoarthritis, in routine cases, you don't need any additional imaging such as MRI or CT or ultrasound. Only that should be reserved only for atypical cases or patients showing rapid progression of symptoms. So X-ray is basically our workhorse and gold standard. And it's the most widely used imaging technique to clinically evaluate the stage of the osteoarthritis. And typically, the diagnostics have been done by using this kind of semi-quantitative grading called Chelgren-Lawrence KL grading. And here you can see the grading scale. So basically it means at the grade 0 that you don't see any radiographic features of osteoarthritis, just like here on the left-hand side. And then grade 1, 2, 3, 4, you start to see progressively more and more changes like joint space narrowing and abnormal bony growth, manifested as osteophytes, also bone deformity and sclerosis. And so basically this grading given by the radiologist, this is the standard that we have. And we ask the question that, can AI-based methods help to interpret joint radiographs? So we started this research already like 8 years ago, and we started with very simple texture analysis. So we took the X-rays, we looked at the bone structure, and we analyzed basically the pixel grayscale pixels here, and calculated some texture parameters and associated them with different osteoarthritis grade. And we saw an association of these texture parameters, which basically means that we saw changes in bone structure from this X-ray. We also showed later on that these texture analysis from this kind of two-dimensional radiography, it is strongly associated with true three-dimensional structure of bone. So it seems that if you have bone is three-dimensional structure, you take an X-ray. X-ray is two-dimensional projection, but if you calculate this texture from this, it's a sum. Basically, it's a summation of all the structure which comes into the X-ray beam. And when you analyze the texture of the sum image and you compare that with micro-CT analysis, so here we had the cadaver bones, so you saw fairly nice associations also with these texture parameters to true three-dimensional bone structure. Then later on, after these studies, we started to study also deep learning to actually automatize this classification for these KL grades. So again, remember this KL grades. This is the current clinical gold standard, which classifies the knee X-ray to 4 or actually 5 different categories when counting the 0 as healthy, and we developed a deep learning model to automatize this process. And if we just look at like the binary classification, so typically in osteoarthritis, radiographic osteoarthritis, if you have a grade 0 or 1, so this is calculated as healthy, and then grades 2, 3, and 4 are calculated as osteoarthritic. So if you do binary classification, the model which was actually validated with over 18,000 images and validated and tested with several thousand images. So it gives you fairly nice automatic classification. And also, besides this, just giving you this one class grade, so it also gives you the grade distribution. So basically you see that, for example, in this case, it shows you that with 56% there are features from grade 2, but 43% are features from grade 1. So this is a little bit unclear case. So if you need to put this image to one grade, it would be grade 2 because 56 is higher than 43%. But it's certainly not very clear in this case. Maybe the proper grade would be 1.5 perhaps. But in this case, grade 3, so more advanced disease, the model says that 90% of the features which should belong to grade 3. So this would be then more clear case that okay, this would be the grade 3. And the model also gives you this kind of heat map, so that basically it shows that where in the image are those features that it has used to give you the prediction. So this model was published a few years ago, and it is actually freely available in the internet and GitHub, the whole code, so that wherever you are, and if you want to try it, you can take a knee X-ray and analyze that with this model. And also we showed that this algorithm had good agreement with human radiologists. So we took also our own data set of subjects from our own hospital, and that was even a different population because the model was trained with the population from the USA, where we were able to extract this openly accessed database. And then of course our own subjects were from Finland, and also the X-ray equipment was different. And we saw pretty much similar agreement values that you get between two human radiologists or human readers, and then if you would replace one human reader with computer, so we get the same agreement. Clinically, actually, so in this study we use deep learning to predict the grade of the image, but of course patients really care what is the grade. So if you have an osteoarthritis or any disease, it doesn't matter what is the grade of your image. What matters more is that you should know that whether your disease is going to progress, and of course whether you will have symptoms. So in this case, we tried to predict the progression of knee osteoarthritis. We made the deep learning model to predict whether the radiographical osteoarthritis will progress within 7-year follow-up time. And we had almost 5,000 knee X-rays in training phase, and in testing phase we had almost 4,000 knee X-rays. And if we had an increase in the scale grade within the following 7 years, then we counted that as a disease progressor. And if you didn't have that increase, it was a non-progressor. And this was the first study actually where deep convolutional neural networks were utilized to predict osteoarthritis progression directly from radiographs. And we got quite interesting finding here that we saw that the performance was as good as with conventionally used parametrical predictors. So we actually compared the prediction directly from the image with typically used parameters like age, sex, body mass index, whether you have a surgery or whether you have an injury or have had earlier, and what kind of symptoms you have. So basically these kind of clinical background information that you can get. So our results showed that you can actually get the same level of prediction directly and automatically from the image. So we didn't get any additional value when we were supplementing the image with this clinical background data. Of course, this is not the first study anymore. So now there are much more studies where convolutional neural networks have been utilized to predict osteoarthritis progression. And in this study also the progression, besides just predicting the progression, like here, for example, X-ray images in different time points, we also have these heat maps to show that in which areas this progression might take place in the future. So it is predicted to take place. A clinically important finding in the study was also that it could predict osteoarthritis progression for the subgroup of knees which were identified as KL0 or 1 at the baseline. So KL0 or 1 at the baseline, this grade means that they would be evaluated clinically as normal. But the model was actually could predict in several cases also the progression for those ones in fairly good accuracy, AUC of 0.80, and this is of course clinically important, because if you take a knee X-ray, you look at it and you would say visually, okay, it's normal, but actually the model would say that no, it has a high probability of progression within the near future. So this might be clinically important. Okay, so we are gonna approaching the end of the talk. So as a take-home message of this talk. So we learned that the clinical imaging methods at the moment, they are limited in spatial resolution to characterize early osteoarthritic changes in joint tissues. We focus and in joint tissues, we mean articular cartilage, subchondral bone, and meniscus tissue. We also learned that ex vivo imaging methods allow identification of histological early osteoarthritic, or in some cases we could even talk about pre-osteoarthritic changes, because that's actually a very nice philosophical question. When does the osteoarthritis starts? Does it start when you have some really minor molecular or structural changes in the tissue, or does it start when you actually start to have symptoms? This is would be a question for different day to discuss. But we can talk about like a pre-osteoarthritic changes. We can see like really early changes, and it's possible to identify the early changes in different osteoarthritic phenotypes. At the moment, the methods that I was showing today are limited to ex vivo imaging, but as you saw, there might be a possible to translate them to in vivo in the future. Also, we saw that the sensitivity of clinical X-ray imaging, it can be improved with modern image analysis and machine learning techniques. And probably it means that in the future, we will create more and more accurate clinical prediction models. And it is very important to highlight that combination of this high resolution imaging data with tissue level biomechanics will increase our understanding how structure and composition affect the biomechanical competence of joint tissue. So at the moment today we were focusing on imaging, but it truly understand, for example, the joint tissues and joint as a unit. We need to integrate this information to biomechanics. So this is the way to go, and this is of course what also we are doing in collaboration with, for example, University of Eastern Finland. Some of the future directions also what I want to highlight at the really end of the presentation is our new European level project focusing on low back pain. So low back pain is actually the largest cause of morbidity worldwide. And similarly, as in knee or hip osteoarthritis, we don't really understand well the exact etiology of the low back pain. And similarly, as in osteoarthritis, links to, for example, to intervertebral disc degeneration, which by the way contains cartilage, and the spine contains bone, so same tissues that we have been looking at today, not exactly the same of course, but the same tissue types, degeneration of those tissues and their links to symptoms, it is not very well known. And if we add into the equation the genetics and environmental and cellular responses and psychosocial factors, like is done in this Disc for All innovative training network. So actually this training network, which was initiated like started last November, the aim is to integrate available data and computational simulations on low back pain caused by intervertebral disc degeneration with the multidisciplinary translational medicine approach. And here actually in this project, we will nicely connect the biomechanics also with these imaging findings. This project will use the unique population cohort data from UK and also here from Oulu. And a lot of AI-based techniques will be used to generate interpretable prediction models between measurable clinical data and unmeasurable but hopefully predicted key regulator of cell and molecular activities. So please take a look at the web page of DISC for All. At the moment, actually, we have a call open for 3 early stage researchers, so basically 3 PhD students within this network. So take a look at the web page if you are interested. Finally, I want to thank my wonderful group, which of course without none of this would have been possible. So I'm truly lucky to work with so good people as good people and talented people as in our group. So with this, I would like to thank you, and I'm ready to take any questions.
Yeah, thank you so much, Simo, for this great presentation. Really exciting to hear about this state of the art of these imaging modalities for osteoarthritis. I think with that we can move to the Q&A part. I've already received 2 questions. For everyone else, please write your question in the chat box and I will read them out to Simo. I have to apologize, I can't see who is asking the question, so it will be very anonymous. The first question goes, I'm a bit surprised. In the first slides, there was a picture of FDIR of a healthy cartilage with much more collagen in the deep zone than in the superficial zone. Did I see it correctly? If yes, isn't it contradicting biochemical measurements?
Okay. Yes. Okay. So thanks for the question. Yeah, this is actually a really good, really good question. We have been talking about that for years. So yes, if you take these old biochemical biochemistry studies from Marodas and what were those 70s, they actually show that you might have more collagen. It actually would go like this: so superficial, middle, and then deep. But deep would still stay below the superficial. Yes, so you are right. It is contradicting. But considering the, let's say, the depth-wise resolution of the biochemistry and also the samples, if I remember correctly, they came from hip, probably in those old works. So we actually believe that that when you use these microscopic techniques, that you get better estimation of collagen content than with biochemistry, because another reason is that in biochemistry you always need to normalize to your measured value with, for example, the tissue wet weight or dry weight. And when you actually slice the small tissue sample as cartilage, so you introduce also some bias in this process when you normalize. So, but having said that, it is still, I mean, old biochemistry work still show that, and it is a little bit contradicting. So, yeah, actually, we tried to do some study also to section the cartilage and did biochemistry, but our results were not really reproducible, so we couldn't publish them. So we cannot show direct comparison. So it maybe remains a little bit open. But that's for sure that also in FTIR you see a peak in collagen content at the surface. So you see it like this, then it goes down, and then it goes up again. So the question is only whether it goes higher at deep zone than at the superficial zone. This is where we don't maybe know completely.
Okay, great, thank you. So the next question, haven't you tried correlations with quantitative clinical image modalities for soft tissues, e.g. T2 mapping, MRI? I'm wondering about the effective added values of automatic K-added grading. By default, the K-added grade fails in detecting early OA. In contrast, novel grading systems based on soft tissue imaging would be more powerful for early diagnosis. Could you comment on that?
Again, excellent question, and I wouldn't mean to say that that MRI wouldn't have value here. So actually, we have done a lot of MRI studies, and my colleague Mika Nieminen is actually focusing on especially the cartilage imaging with MRI. So I would say you are yes. And KL, and I agree here that predicting the KL grade itself is not really a big deal, because as I said already, the patient really doesn't care about KL. But if we could show that the X-ray has some intrinsic information which would correlate, for example, with fast progression, so then you actually might have the clinical value of X-rays. But can it have, without MRI and soft tissue contrast and let's say soft tissue parameters like T2 of the remains to be seen. So our kind of aim is to get as much as possible you can from X-ray, because that is available everywhere, and then MRI certainly is the most comprehensive imaging modality of the joint at the moment, especially for soft tissues, and it certainly will have value in the future, also in progress and prediction. But the true fact is that MRI is taken quite rarely in case of osteoarthritis. So if you could get some more value from X-ray, that would be maybe clinically more relevant. Research settings, if I would plan a research trial, I would certainly include MRI, because I would like to understand as much as possible what is happening in the joint. But clinical world, you might not always get MRI.
Okay, thank you. Another small question about the deep learning model. How many samples images did you need to train the deep learning model for the super resolution imaging study?
Excellent question, and the proper answer here is as much as possible. And then the answer, of course, we were limited with the number of samples. So I think we had like a few tens of samples. So it's certainly not much, but of course, when you train the model, you can kind of artificially generate more samples with augmentation methods. For example, rotating or looking at making the reconstructions in different orientations. So you can artificially increase the number of samples used in the training, but obviously you don't have the biological variation more than you have in this sample set. And I would say that yeah, as much as possible. Of course, deep learning always requires, but we got surprisingly good super resolution results with this limited number of samples, and it was indeed also quite surprising that how well it also worked with the clinical data, but still much work to be done.
Thank you. All right. The question: do you think that deformation of collagen fibers under mechanical stimulation could be imaged with micro-CT?
That's a really good question. So at the moment, our micro-CT, those results that I was showing, so basically they concern the fixed samples. So to look at the live situation for a compression of the tissue and compression of the fibril network live, you would need to basically image a sample in the hydrated state and use maybe some other contrast method. I would say that maybe in the future phase contrast micro-CTs, which actually can give you a quite good contrast, might be suitable for that. But also the problem is that in micro-CT you have fairly long imaging times. So in order to get this resolution, sample needs to stay quite long time in the scanner. So again, like in those scans, many scans took like 6 hours for one sample. So that's probably too much for one biomechanical live test at the same time. But it is possible, and actually we also, in principle, we also have the load cell what we can connect with our micro-CT. But with these contrast agents, it's not possible. And with this resolution also, I think you need maybe decreased resolution.
All right. Then question, can early stage detection of osteoarthritis lead to early treatment?
That is an excellent, excellent question. This is what we hope, obviously, and I would say that because this KL grading, what I showed, this is the gold standard at the moment. It is actually published 1967 or something, like 1960. So we still live with that grading, and we know that this grading is not very sensitive for early changes. And this is still the grading what has been used in clinical trials to select the candidates for the OA treatment. So I believe that, and I'm not the only one believing this, that we have in previous trials, we probably have missed some certain phenotype of osteoarthritis, which might have benefited that drug candidate that was tested. But now we kind of pooled all the phenotypes together using only the X-ray as a selection tool, and then at the same time we also used this cutoff KL number 2 as a limit for osteoarthritis, which probably has already in some quite advanced stages in some cases. So I believe that we should have the early diagnostics first to get the proper treatment trials ongoing, and hopefully after that we would be able to treat also early OA. And actually this goes back to what we discussed about MRI. So if we would use the MRI in combination with X-ray to select patients to clinical trials, that would be much better than using only X-ray and this KL grade. If we don't find out this progression prediction method that, okay, from X-ray you can already predict those fast progressors, for example, and then you would select those ones to treatment trials which shows this fast progression prediction. But so far MRI is the most comprehensive, but let's hope that we will have the treatment for early OA also. And actually, still one continuation of we do have the treatments. It's the losing of weight, doing a proper kind of physical exercise. We do have a treatment, but people tend not to like it because they need to do the work by themselves. So people probably would like more of a pill. Drug which you just take and then you get better. So it's the downside. but of course, hopefully we still get that pill one day.
Yeah, thank you. All right. Here one person has 2 questions. I will break them down. First, do you think we could further use any of these techniques to characterize patient-specific cartilage geometry and material parameters in digital twins?
In principle, yes. We regarding the cartilage geometry, I'm not. Let me patients. Yeah. So regarding the patient-specific cartilage geometry. So if you talk about if the question is aiming for the overall joint geometry. So this is like typically at the moment done from MRI scans. But of course we know that MRI has a limited resolution, so we get very roughly the cartilage like the whole morphology. So if we would have a good contrast agent that can be injected into the joint, we could use a CT to characterize the patient-specific cartilage geometry much more accurately than in MRI. But at the moment, it's not very. First of all, that contrast agent is PTA that I was showing in my presentation. You cannot inject that. That is toxic for, it's not physiologically possible to inject that. So you should have some other. But regarding the material parameters and digital twins, so of course the aim that we have been taking is that we actually image these tissue samples in different disease phases with ex vivo imaging methods, and then our colleagues built kind of for example, the biomechanical models based on this information. It's not that good than getting the high resolution geometry for the whole individual patient, because you need to work with only the samples. But it is still better. It is still one approach. And maybe in the future, when we get the increased resolution, we could actually also get the cartilage geometry in 3D in high resolution clinically.
Yeah, great. Then the continuation of the question, would any of these techniques be economically feasible in daily clinical practice? And how would you be able to combine? Oh, I think that's another question. Yeah, sorry.
Yeah, so with these techniques, I would say that CT, cone beam CT, is obviously it's already used in the clinics to image like ankle joints and well knee joint also and wrist. So that is certainly so. If we can show, for example, with the deep learning, that you can get the better prediction of the disease progression, for example, using the CT data than you can get from X-ray. So that could be directly then clinically used, and it is quite feasible. It's not expensive. The cone beam CT, you get very little radiation. So basically it's a quite nice technique. Then regarding the other techniques I was showing, we have actually another. So for Ir Spectroscopy. So we have an ongoing EU project at the moment where we have tried to miniaturize the FTIR probe that surgeon can insert that into the joint during the arthroscopy. So basically, you can measure the spectroscopic, you can measure the infrared reflection from the cartilage surface within the knee joint during arthroscopy. So that's the aim of the project. So by that way, you could do this measurement, but this actual imaging, FTIR imaging, would mean that you should be able to measure like different points. It's much far away from the clinical practice. But what you could do this measurement from certain spots that surgeons are already looking when they go inside the joint during arthroscopy, and then you would get this basically this information that I showed, that okay, cartilage looks normal in the view of an orthopedic surgeon, but then he or she would do the measurements and they would see that actually it's not normal here. So that way you could apply that.
Okay, thank you. The next question: how would you be able to combine imaging with tissue level biomechanics? Could you give some hint? And can we also predict disease progression through biomechanics infusion?
Excellent questions again. So we have another EU project where we actually look at that aspect. So one of the aim of that project is that my colleague Professor Rami Korhonen from University of Eastern Finland, they have the joint specific finite element models, basically where they simulate the gait cycle and then they look at the tissue level biomechanics. And their models, they basically use the imaging data to look to build the geometry and build the material properties. So actually there we go back to the MRI. So MRI with T1, T2 scans, you can get some estimate of the material property of a tissue, which you can then implement to the biomechanical models. So basically geometry and material properties, those are the ones you get out from the imaging techniques, and you can then implement them to the models. And the methods that I showed today can be also used, but as I said in my previous comment, that then we need to limit ourselves to ex vivo imaging and use that information, extrapolate that to the in vivo models. Regarding the predicting of disease progression, this is very interesting question, because you can predict the disease progression basically like patient specifically using the biomechanical approach. So for example, you can show that in certain areas you have very high stress concentrations, and of course that is probably showing you the locations where the tissue is going to fail in the future. Or then you can take this deep learning approach that you don't actually care what is really happening there. You take the input data at baseline images, basically the same input data that you use to build the finite element model, and then you predict what's going to happen in the future. And then the question is, which is working better, which is predicting better the future, and which is giving you more information in the joint. Those are the things which then defines what approach you should use. So basically, with I would say that with the deep learning methods, you probably can get decent prediction of disease progression. The question, actually, what we are looking in this one project is that how much it adds when you add the patient-specific biomechanical prediction. So is it adding anything? So we are gonna look at that in the next 2 years. But so that's the one side of the coin, clinical prediction. But then, if you want to understand what is happening in the joint in progression, so then you need those biomechanical models to, for example, to look at those stress distributions and tissue deformation. So it really depends basically what you want to predict. But I would say that like a combination of biomechanics and deep learning, this is gonna be the future, and then eventually we will see then which has the best clinical value.
Great, thank you. I see 2 more questions. First, regarding the classifications you found in the meniscus using micro-CT, how are you planning to analyze those? You mentioned different gradings of them. Could you also elaborate on that?
Yeah, thanks. So these were truly the new results, and yes, we are planning to analyze these. So we want to, for example, the same way that we quantify these chondrons in the articular cartilage tissue. So we want to quantify for example, how much calcifications we have within a certain volume, or what are their like morphology, and if that has some relevance to the disease. Yes. And this grading was fairly simple at this point. So it was mainly looking at this whole image stack that we image and saying that if you have some minor calcifications here and there, then you get a smaller grade. That if you have more of the calcifications or larger of them, you get higher grade. So we are actually gonna present this grading scale first time after 1 month in international workshop of osteoarthritis imaging. So after that there will be more information on that grading scale also. But having said that, we are certainly gonna go for quantitative analysis also.
Okay, thank you. And then 1 more question on the deep learning model. Osteoarthritis causes joint space narrowing. How are you able to ensure that the deep learning model doesn't confuse this with malalignment? Excellent question. So basically, if we think about the deep learning model, it analyzes everything that is inputted there. So obviously, the model itself, if there is a malalignment, so or the joint space narrowing, some cases they might show quite similar, and the model itself obviously cannot differentiate them if we don't tell it specifically that this is the joint space, and we haven't done that. So at the moment what it does is that it's basically predicts what it has been trained to predict, and whether it's a malalignment or whether it's joint space narrowing, model doesn't really care about that. It just analyzes it. But it's a good point that we could, of course, teach the model separately, trying to find features of joint malignment irrespective of joint space narrowing. Okay, thank you. Then we have 1 more follow-up question. I suppose on the calcifications that you found in the meniscus. Why do you think these calcifications occur?
That's really difficult question. I cannot answer this at this point, because it's the same. In some cases we also see actually calcifications articular cartilage. They are much more uncommon than in meniscus. So in cartilage they are very rare, and there is even in separate disease in cartilage called calcium pyrophosphate disease, which is typically characterized for this calcification within articular cartilage. So why do they occur? It's a really good question. We are gonna those meniscus calcifications. We are gonna look at those more specifically within the next few years, and hopefully we have some more light information on that.
Great, thank you. So I don't see any more questions. So thank you again, Simo, for this great talk. And also thank you everyone for joining the webinar and also for the questions asked. It's a great discussion. And yeah, we hope to see you in the next webinar.
Yeah, thank you on my behalf. It was a pleasure to present in this webinar.
Great to hear. All right, then. Good day to everyone. Bye-bye.
Thank you. Bye-bye.